introduction, and I'm really glad to be here today. So, in terms of things that I thought maybe we could focus on this year, I really honed in a little bit on sort of the approach to weight loss in people with memory concerns. And then I'd like to talk a little bit about strategies to really optimize nutrition and hydration. And then I received a number of questions last night. And so I've tried to add some slides in to answer those as well. Because I thought, rather than me telling you what I think you might want to know, it's better to get your questions answered thoroughly. So I appreciate everyone who sent those in advance. So we're going to cover a couple of cases. The first, over the last few years, you've noticed that your loved one is repeating things more frequently and having more problems with their short-term memory. They don't have any kind of memory diagnosis. They've lost about 30 pounds in the last year, and they seem to have a tendency to eat toast and cereal. They seem to be missing meals. There's some expired food in their refrigerator. Uh, you went over for dinner and the beef that they served seemed to be undercooked. So we're going to talk about some strategies for this. Then we'll have case number 2. So you have a loved one that has a known diagnosis of dementia, and you've noticed some gradual weight loss. You worry that they might not be eating enough. And you're just wondering more about nutritional supplements or what else you can do to supplement what they're eating. And then the last case we're going to talk about is your loved one has fairly significant dementia. They're starting to lose weight. You think they also are not drinking enough liquids. They really won't sit down for meals. They seem to decline to eat anything that you're providing them. And you're wondering what else you can do. And then just as a quick disclaimer, I'm going to talk to you today and sort of give you a really general approach to things and kind of explain my thinking and how I approach these things. But I would always encourage you to consult your own medical team with your own health concerns, because what I'm going to say today is really general and may or may not apply to you. So, as a geriatrician, when I'm approaching someone who may or may not have a diagnosis of a memory problem, but they are losing weight as an older person, I sort of try to look at the whole picture. And there are sort of 3 broad categories of problems that I typically encounter. And when I'm trying to come up with a treatment plan, I try to address sort of all the categories at once, rather than trying to kind of pick one thing at a time to do. And with the goal to try to stabilize that weight loss so that their weight kind of stays steady or ideally gains. So the first thing that I try to do is establish whether the person is eating enough or not eating enough. And usually I try to do this just by asking the person and their loved one, what are they usually eating for breakfast? What do they have for lunch? What do they have for dinner? What do they have for snacks? What do they have for drinks on a typical day? And from that, I can broadly determine, is this person not eating enough to sustain themselves? Or are they eating enough but still losing weight? And if they're eating enough and still losing weight, that's often a flag that there may be something sort of in that medical bucket going on. The next thing that I always look at as a doctor for older people is medications. And I would say by far and away, this is a very common category of problem. And, a thing I often hear is, well, that medication can't be the cause because they've been on that medication for a really long time and they never had any problems before. And the thing you have to remember is that when we get older, our livers don't work as well. Our kidneys don't work as well. Our body is more sensitive as well. And so something that you may be tolerated without any side effects of appetite suppression or nausea or vomiting in the past, you may now be more prone to having side effects. And so the first one on the list, which comes up for many, is actually the medications that are out there for dementia. So the first class is the cholinesterase inhibitors. So you might know it as donepezil or galantamine or rivastigmine. In the studies, about 1 in 12 people had significant stomach upset type of side effects. So that is definitely a common one that I would flag you to. If you sort of think back and say, well, my loved one had a good appetite and then they started on that medication and now a couple years later, they're really seeming to lose weight, that's a big one. Memantine is another medication that's used for memory. It doesn't suppress appetite as much, but it's certainly something that can also contribute. The next thing I look at is the person's supplements. So a lot of times we don't think about it, but some supplements are very hard on your gut. So even things that, seem benign, like calcium or iron, those can significantly suppress appetite. Then I'll think about substances. So maybe the person is drinking alcohol or smoking, and that's suppressing their appetite. Diabetes medication is a big class. So I'm sure many people have heard about sort of the Ozempic craze. People are using it, for weight loss. So much so that there's a drug shortage, but it's also a medication that's commonly used in diabetes. And so many people, they've been on that medication, they've been able to gradually lose weight, and now it's kind of gone too far. Or metformin, again, a first-line medication used for diabetes, but causes a lot of stomach upset issues. And then I've listed some other ones, again, also quite common. So then, what do we do from there? I don't just stop every medication that might be causing someone's appetite to be suppressed. I try to look at, why was the medication started, and do you still need it? So that involves, looking at your different medical conditions, looking at blood work that you've had, looking at other specialist notes. The next thing I'll think about is the route of administration. So for example, iron, maybe you've been taking it by mouth and it's been suppressing your appetite, but maybe you could take it intravenously and it wouldn't suppress your appetite. Or osteoporosis medications is another example that, you take it by mouth, it can suppress your appetite, but if you give it intravenous or intramuscular, you won't have that kind of side effect. And the last thing I really hone in on is this idea of a prescribing cascade. And what that means is, say you were started on a certain medication and then that caused a side effect. So then you were started on a medication to control that side effect. Sometimes if you look back at the initial medication and determine if that was needed, you can sort of get rid of multiple medications that were added to control other side effects, basically. So once we've kind of looked at the medication list very carefully and determined what can be given by a different route or what's not needed anymore, then we'll kind of look at the medical situation. And, I think people are most often concerned that, they might have an underlying cancer or something that, is contributing to the weight loss. Which certainly can happen, and it's something that we think about, but I tend to take sort of like a head to toe approach to kind of look at all the things that might be potentially causing problems. So thinking about things like, is there any kind of neurologic symptom or headache to, suggest this person might have a bleed in their brain or a brain tumor or something that's suppressing appetite through that mechanism. We're talking about cognitive problems, so I think that, everybody here maybe comes with a baseline of that, but sometimes we don't know if someone has a cognitive problem. So we often will screen cognition to sort of see if that might be affecting their ability to eat. We'll often do some mood and behavioral type screening. So, is the person very depressed and therefore not eating, or maybe they're spending a lot of time pacing and that is kind of contributing to this weight loss. I'll ask them about their appetite. Do they feel hungry? Do they feel excited about what they're going to eat, or do they look at the plate and kind of push it away? I'll ask them about their teeth, how their dentures fit. Do they have any problems chewing? Do stuff get stuck? Do they cough and choke when they eat? I ask them about heartburn and stomach pain. And, do you feel full really quickly after you've started eating? I'll ask them about bowels. Constipation is a very common thing in older people, and it's a really potent appetite suppressant. If you haven't pooped in a week, you're not going to feel like eating anything. When we're thinking about cancer, we're often asked, have you had fevers? Do you have, soaking night sweats? Are you having shaking chills? I'll ask, how much weight kind of have you lost? And then I kind of do a physical examination. I'm looking for signs of, illnesses that might be contributing. So that's kind of the third box there, that medical and medication things. Now we're going to hone in a little bit on sort of how cognition kind of changes your appetite a bit. So what you'll notice is for many people, they have more difficulty interpreting their hunger or thirst signals, right? So they won't always respond to them the way that they might have in the past. You'll also notice that the palate gets more simplified. So they might have loved, salmon and wild rice, but now they're more interested in chocolate bars and chips. And another big piece with appetite is just kind of forgetting, like, have I eaten? When was the last time I ate? What did I eat? Perceiving that I've eaten more or less than what I actually have. And I think, if you've been to any of Jeanette and Christie's talks, they talk about the 8 A's of dementia, right? So, impaired attention skills, aphasia, like language skills, apraxia, so inability to do things. But basically, the idea is all of these symptoms that people get when they have a memory condition are going to affect that perception of appetite. And then lastly, just kind of honing in a little bit on kind of the person's functional ability and kind of their social context. So the key to remember here is that things that used to be really simple or very automatic will take someone a lot more mental energy to do. And at some point, it will break down. So what do I mean by this? I give the example often to families about like making a peanut butter sandwich. So I think most people who, have normal cognitive ability, they think about making a peanut butter sandwich and they think, okay, well, there's like 3 steps. You gather the ingredients, you put the peanut butter on the bread and you eat the sandwich, right? But the reality is when you think about all those A's of dementia and how they affect every skill that we have, when you ask an occupational therapist, they will tell you that it actually takes over 30 steps to make a peanut butter sandwich, right? You have to know where the supplies are located. You have to know what a knife is. You have to know what bread is. You have to be able to have the motor skills to do that. You have to be able to count. You have to be able to measure, right? So I guess just what I'm trying to say is even the simplest thing can actually be very difficult and take intense mental energy for people to do. And at some point, they will not be able to complete all the steps required to make a meal. In terms of these functional changes, you can kind of divide them into categories like problems with shopping, problems with cooking, problems with eating. So if you're thinking about problems with shopping, right, the person might have difficulty planning a meal or making a list. They might be coming home with the incorrect items. They might buy multiples, like too much or too little of something that they need or didn't need. Their cupboards might be full of food. You might look in their fridge and all there might be is condiments, right? You might notice that they have difficulty in the store or difficulty, paying for their food in the store because they don't remember things like PIN numbers. Thinking about problems with cooking, some things you might see are, focusing on really simple things like toast or cereal, because there's kind of an avoidance of more complex tasks. So they've kind of lost that planning. Miscalculating cooking time, undercooking or overcooking something. Spoiled foods not being thrown away. I get this all the time, like, oh, mom did great. She cooked a roast last week, but here you look in the fridge and, you're still eating off that roast, 10, 14 days later. And that's probably not safe. People getting mixed up during meal preparation or just getting overwhelmed, having to walk away from what they're doing, leaving out important steps in recipes, over or under spicing things. And then there's that struggle with appliances, right? Of, leaving the stove on or not setting the timer or putting in the wrong temperature, too hot, too cold, not knowing how to run the microwave, even though you've written down all of the directions for how to operate it. And then problems with the actual eating, right? That's where people forgetting whether or not they have eaten. Another sign you can look for is, they eat really well when you're there, but then when you leave, the eating just doesn't seem to be happening. There might be challenges with utensils. There might be challenges with pacing, eating really fast and kind of getting things everywhere. There might be chewing or swallowing difficulties. People can eat inedible things that you shouldn't be eating. Just complete loss of interest in eating or drinking, or kind of some of those food craving pieces that we talked about. So, you as their loved one, you're going to be a little bit of a detective. And so some of the basic things or first things that you can do is think, well, have I observed them at the actual grocery store? Have I actually seen them make anything? Have I looked in the fridge and determined, what's in there? Is it just condiments or, expired things, or is there sort of evidence of order? And then is garbage going out every week, as a sign that things are sort of being consumed on a routine basis? Often people will ask me, well, what if I don't have a family doctor and my loved one's losing weight? Like, what can I do? And I think I've tried to summarize some of the resources that are available. So if you're looking at medication and supplement review, your pharmacist can be an excellent resource, and they can do a meds check and really sit down with you and at least be a starting point for helping you know which medications might be suppressing appetite. And then, when you're accessing some other source of primary care, like even a virtual care, walk-in or emergency department, you at least know what questions to ask. If there is teeth issues or dentures, making sure that they fit properly or that they've been, relined. If there's any sign of a swallowing problem, like coughing when someone eats, you don't need a doctor referral to talk to a speech and swallowing therapist through home and community care. A dietitian can be very helpful. Again, you don't need a referral. You can self-refer through home and community care for a dietitian. And also you can self-refer for an occupational therapist. So if you're not sure if your loved one actually knows how to cook or what the steps are, you could have an occupational therapist come to the house and kind of work with them on that. And then obviously, at some point making that connection to a doctor so that that medication and medical workup piece is completed thoroughly. So kind of thinking about this approach that we've developed and kind of coming back to the cases. So this is a person that, doesn't necessarily have a memory diagnosis, but they've lost a lot of weight. And there seems to be a tendency to eat a lot more simpler things. There seems to be missing meals. There's some expired food, issues with the actual cooking. So in this particular case, we're not going to dive heavily into the medical and medication piece. But again, as I've said, there's often lots of pieces there that can be optimized. but we're going to hone in a little bit on kind of some of those functional problems that were observed in this case. So I think sort of tip number one, when people are having difficulties either with the shopping aspect or the preparing aspect, there are lots of resources to help them get access to nutritious food. So meal planning, so sitting down with the person and planning out what are you going to eat this week, working through creating a list together and getting items together can be helpful. Sometimes that's all someone needs to be able to continue to be independent with their cooking. You can also do like grocery delivery services. So if you live far away from your loved one, you can go through that meal planning on the phone with them, order groceries online, have them delivered, right? And then you can at least get that part of things, like, is it the shopping piece? Get that sort of addressed. Another big tip is I do find that generally people eat better when they're eating with other people. So that might mean us, having a regular routine where Mondays they go to this child's house for dinner, Tuesdays this child's house for dinner, Wednesdays somebody else's house. You can add in things like adult day program, right? So all of the communities have a day center where people can go for the day and have lunch with other people. There's also dining clubs. So again, I've put the number for Community Support Service Central Intake, but there is one in Clinton, there's one in Seaforth, there's one in St. Mary's, there's one in Mitchell, there's one in Stratford, and they exist, throughout. I'm probably leaving some out, but that's a really good opportunity. And often there's also like some entertainment associated with things like that, or some type of social aspect. So that can be helpful as well. Some people need help with actually preparing the meal. So, some things that families will do is, hire a private pay, like a housekeeper or cleaning person who is also good at cooking, to come a couple of times a week and prepare some food together with the person. That way, when things are prepped, it's easier for the person to reheat things, or they have all the ingredients kind of ready to go. There's also local church groups that will do like a prepare meals together, kind of a program where everybody comes, prepares the meals together and takes things home. There's hot meal delivery, right? So I think people hear a lot about, the Meals on Wheels, whether it's hot meal or whether it's a frozen meal. Sometimes I do hear that people, like, that's not maybe their first choice. There are a number of other meal services, and if anyone wants names of meal services, I can provide that information afterward. Another common thing is actually having restaurants deliver, right? So a family could call the local restaurant and say, every Tuesday, I want you to deliver Chinese food to my mom. Or like in Mitchell and St. Mary's, they actually have those programs already organized through the senior center. So they have certain nights where restaurants deliver to certain people's homes. So if you're needing to access kind of any of these resources, the Community Support Central Intake number that I put there is a really good place to start. And the other little star is, I often hear people say, well, my loved one doesn't want me to help them with meals, or that, they don't think they need any help. And sometimes these types of things can be a Christmas present, they could be a birthday present, right? So all of a sudden they're, for their birthday, they just got 10 frozen dinners that they can, heat up over the next little while. So sometimes you have to be a bit creative. I think kind of the second tip is to really make the most of what you are eating. So if people are not good at sitting down to full meals, I often encourage people to focus on kind of having a really like high protein, high calorie snack more frequently, and less focus on big meals. I also talk about, choosing your favorite foods. right? So, don't bother eating things that the person does not like just because you're trying to offer a balanced diet. Like, hone in on the things that they actually like. You want to avoid anything that's diet, low fat, low sugar, low calorie, right? I mean, those products were great back when they were helpful in our lives, but now that's not anything that you want to be providing. So just some examples of how you can kind of boost up the protein and fat and calories in things that people are already eating. So instead of skim milk, you could have homogenized milk, or you could even have cream in your cereal or in your porridge. Instead of black coffee, you could add cream and sugar. Instead of fat-free yogurt, you could have Greek yogurt, which is high in protein, or you could have 10% fat Mediterranean yogurt, just so that you get a lot more nutrition in the same kind of serving. Instead of having dry toast, right? Have your toast with a layer of butter and then a layer of peanut butter and then a layer of jam, or have it with cheese. Instead of a broth soup, have a cream soup. This is a website that I came across. There's probably lots out there, but it just lists recipes that people who have a memory problem might be more interested in eating. So, some of the ones that I will recommend to people, anything that's a baked good often has a lot of fat and calories in it. Pancakes are a good one because they're, you can put lots of things in them and they're kind of bite-sized and easy to eat and soft. Anything with eggs or mini quiche, cottage cheese, whipped cream, any kind of dairy products. Any meat or fish or beans. So for example, meatballs, even if they can eat 2 meatballs, that there's a lot of nutrition there. Anything with nuts or seeds. Frozen dinners tend to have a lot of calories in them because people add those in to make you like them. And so that's something you can use to your advantage. And often I talk about the porridge plus, right? So instead of just the plain oatmeal, add everything into it, right? So you can add protein powder, you can add cream, you can add nuts on top, you can add fruit on top, right? Just increase the density. So let's shift a little bit to case 2. So this is a person that kind of already has a diagnosis and you don't think they're eating enough. And you're kind of wondering about nutrition supplements or like what's out there from a supplemental perspective. So the first thing I would say is supplement what they are already eating. So kind of relates to what we talked about before. But that's that idea of, if they like mashed potatoes, add lots of butter. If they like roast beef, make sure it's got gravy on it. If they, if you're going to have a dessert, add a big dollop of whipped cream to it. Add cheese as a sprinkled on top of things. You can add protein powder to soups. So it's just that idea of increase the density of what you're already eating. And this is just a little example. So say you just ate half a cup of boiled potatoes, right? There's almost no fat, almost no protein, a small amount of calories relatively, compared to if you put all kinds of other goodies in with those mashed potatoes. All of a sudden, you've dramatically increased your protein, your fat, your calories. And then in terms of supplement, people will often ask me about, the nutrition supplements that are kind of on the market. A couple of tips before we kind of look at some of the different ones. So the first is you generally want to offer these in between meals, right? So the thought is that if you offer it before they eat, they might not be hungry to actually eat because the nutrition supplement will fill them up. So you want to eat your regular food, then follow that with your nutrition supplement. The next thing you want to take a look at is how much liquid you think your loved one can drink. So nutrition supplements, kind of the standard size is about 250 milliliters. but they also come in compact varieties where you get the same amount of calories and protein and fat, but in half the volume. So those tend to be a bit more expensive. But sometimes that's a better option if you don't think the person will actually drink a whole nutrition drink. And the other thing I just highlighted there is you want to pick one that has adequate protein in it, right? So look for something that's more than 10 grams. Just because sometimes people will actually get a diet shake or something else that they think is a nutrition shake, but it's actually not got that much in it. So I've listed some of the common ones. I will alert you to the fact that pretty well every store has their own store brand. And so if you look at the nutrition facts on a store brand bottle and it's the same as one of these, and it's cheaper, then I would definitely say, go for the cost-effective strategy. So the first two that I have on this chart are a smaller volume container, kind of what I was talking about before. So the Ensure Compact is 118 milliliters. So it's a bottle like about like that. And in that, you've got 220 calories and 9 grams of protein. Another thing that I will often use is the next product listed called Resource 2.0. So it comes in like a juice box type of size. It's usually ordered through the pharmacy by prescription. But what you do with that is you parse it out into a shot glass and you offer the person sort of a shot glass full of the liquid after breakfast, after lunch, after supper, and before bed. And because it's a highly concentrated product, you're getting about the equivalent of 2 Ensures in over the course of a day. Then I've listed, just a couple of the other, so Ensure Plus, Boost Plus. There's a Kirkland product through Costco. Again, every store has a brand. And I've kind of listed, what's the bottle size? So how much do they have to drink? How much is the calories? How much is the protein? And what's the cost per milliliter, right? Because sometimes cost, really is your biggest factor. And another piece, so if if all of these nutritional drinks and things, aren't your style, person doesn't like them, this is a recipe for high protein, high calorie milk. And what you would do is you would use this in a soup, a pudding, a hot cereal, a smoothie, a milkshake, that kind of thing. But basically you take homogenized milk, you take cream, and you take skim milk powder and combine that together and then use that in your recipes. So shifting focus to our third case. So this is someone that has, a more progressive memory impairment. They're really not drinking very well. You have a lot of difficulty getting them to sit down at the table. They don't seem to have interest in anything that you're giving them. What can you do? So this tip is kind of around, or I call it, 24/7 food on the run, or like a grazing station. So what it basically is the idea that you want to pick their favorite foods, you want to put them in bite-sized portions, and you want to kind of put them around the house with the idea that it's something that someone could pick up and eat in 1 or 2 bites, kind of while they're walking around. So things that might work well, depending on what someone actually likes, is maybe possibly a granola bar or a nut or seed product. Again, I put these because they're not perishable, right? So you can kind of set them out and know that it's going to be stable, on their bedside table, let's say for a while. But perishable things also work really well too. So, little mini sandwiches, a deviled egg, cheese and crackers, peanut butter and crackers, a chunk of cheese, a piece of fruit, a bite of yogurt. And again, if you Google this, there's other recipes, again, depending on what your loved one likes. But you just put them around and you kind of encourage them to have those sort of bite-sized servings throughout the day. And I think we've kind of covered that. It talks about, things that are easy to eat with one hand, things that texturally are okay. You can try hot and cold, and then always opting for sort of bite size as opposed to something that's going to take multiple bites. The other thing that I would say is just, supporting the actual mealtime. So, doing things like maybe having a nap and going to the toilet before you sit down to eat. Just that way, your loved one's not going to maybe fall asleep at the table or have to get up and down to the toilet 5 times while they're trying to eat their meal. You want to eat together. So it's kind of the term that's used is kind of like body doubling, which just basically means that you're doing it and you're wanting them to do it too. Right? So the idea is if they see you taking a bite of your yogurt, then they're going to take a bite of their yogurt as well. You can try to kind of make it a bit of an event, like, putting on calming music or, lighting a candle or having some flowers or something that kind of draws them in to the table. You want to minimize distractions, right? So if you're trying to eat and the TV's blaring and your grandkids are shouting and, whatever, all these other things that might be going on, that's generally going to detract from someone's mealtime. You want to present the plate already prepared, right? So don't give a big chunk of meat that the person's then going to have to cut up. You want to cut that for them, put the butter on for them, put the gravy on for them. So all they have to do is think about eating. At some point, people cannot operate a spoon and fork. So sometimes you need to think about finger foods or things that can be eaten more easily with the hands. There are accessible utensils, accessible cups, accessible plates. So if someone is actually having difficulties operating utensils and things, that's where an occupational therapist can be really helpful. Increasing contrast of your table setting. I kind of put a picture here, but it's basically that idea is you want the color of your plate, the color of your food to contrast kind of with the table, because some people actually lose that visual ability with their memory change that they're having. You can try rotating the plate. So if they're only eating one, portion of the plate, but then they always ignore another part of it, turn that plate around for them so they're getting all of it. And, portion, like for some people, a big portion is super overwhelming. So you can put a smaller portion on the plate and then just kind of keep refilling it as it's going down. So shifting just a little bit to touch on hydration. So, we kind of talked about this with appetite change, but, our perception of thirst does tend to be impacted in people with a memory impairment. And the other big thing I find with older people in general is they tend to restrict their liquids because of a fear of, having an accident or having like a bladder incontinence episode. And often I get asked, how much should a person be drinking? And, it can vary a little bit, but most people need 1.5 to 2 liters a day. And that's equivalent to about 6 cans of soda, if you want to think of it that way, or like 4 PC water bottles. And another key, to gauge if someone's drinking enough is to look at their pee, right? Like pee should be, not that stinky and, a light yellow. If your pee is very dark, very stinky, very concentrated, that's a sign not of urinary tract infection, but of dehydration, right? And that's something that we're going to touch on some pearls for that. So in general, when people are struggling with hydration, one of the things is you want to make the liquids really accessible, right? Don't make the person have to walk to the kitchen to get a drink. And make sure you're always providing a drink with the meal, right? And you don't have to restrict. I mean, sometimes we've all been to people's houses where they have those teeny tiny little cups for drinking with meals. And sometimes that's what a person wants, right? But other times it's like if you gave them something bigger, they might actually drink more. So, feel free. And then I kind of talk about like a jug method versus a shot glass method. And so with the jug method, you're going to be getting a person, a cup with a straw, ideally one that's not too heavy, bright colors to draw attention. You want to kind of, fill that up for them, keep it beside them, get a cup holder for the walker if necessary so that that cup can kind of come with the person as they navigate. But basically, that just having that availability of liquid and that ability to monitor and say, okay, I need to drink 3 of these or 4 of these in a day, helps some people to get their liquids in. I do find though, there's a segment of people that get overwhelmed, by the big cup idea. Like they're just like, I could just never drink that. Right. And so sometimes do get them a smaller cup, but you've got to encourage them more frequently to be drinking, right? So say, okay, finish this cup, for me, mom, right now, right? And then 30 minutes later, you have to do that again so that you can kind of get that hydration in. The next thing I would say is it doesn't have to be water, right? We're talking about all liquid content here. And so tips would be focusing on favorite beverages. Like I have some people that just drink chocolate milk. And, at least that gets their hydration in. You can really think about a variety of beverages throughout the day. So maybe they like a cup of tea in the morning, and then a little glass of water, and then a glass of cold milk, and then a cup of coffee, and then you can give them a glass of juice, and kind of you can make a variety throughout the day. Certainly, we can argue about different water flavorings and whether they're healthy or not or whatever. But if some people, if the flavoring will help them to drink the water, then I think that's a positive thing. You can also try offering foods with higher water content. So like a popsicle, for example, there's if you think about a melted popsicle, there's quite a bit of liquid. So sometimes that's something that you can offer between meals to get hydration up. Things like sucking on frozen fruit, sucking on ice, eating watermelon, having a bowl of soup, some Jello, a slice of cucumber, all of these things have liquids. So we can take that all into our, 1.5 to 2 liters. I did want to mention this product. It's new to Canada. So just in the last wee little bit, I have not tried it. So I cannot give any kind of review. But basically, this is a product called Jelly Drop, and it's been used in the United States and in Europe. And these are just little gummy candies that I guess are 95% water. So in Canada, they're going to be sold as these little packages, which contain 9 little drops. And they say that one package is 50 milliliters of water. So you'd have to have 40 packages of these to get your total daily liquids. Like that would be a lot. But maybe, again, if you have someone who's really struggling and every little bit counts, and they like candy, this is a great way, to get hydration in. So, this is a website that you can certainly check out. The other thing to know is you can make your own electrolyte gummies at home. So if you Google, electrolyte gummy recipe, recipes will come up that you can make at home these high water content gummy candies. All right. So that kind of ends my chat about sort of nutrition and hydration. And then we got sort of those other questions. So I'm not monitoring the chat right now. Christy and Jeanette, would you like me to kind of do those questions that were submitted in advance or other questions, or you tell me what you want me to do?
Yeah, why don't we start with those ones? And there's, I think, at least a couple more that have come in, and people can enter those in the chat
Okay.
if they have more.
Okay. Perfect. So the first one that came in is what is the best safety monitoring system for people in Huron and Perth County with dementia who are still going out into the community independently. So I took this as what is the best wandering safety tool, because there is devices that, monitor falls alert or monitor medication compliance. So I hope I'm on the right track with this one. But the answer is it depends. And we're going to talk a little bit here about what it depends on. There is no such thing as this is the one device that's the best thing for every person, at least in my opinion. So the first thing I would suggest is this is a fabulous question for your Alzheimer Society first link counselor, because they know about you and they know about your loved one, and they can help you make the best selection for you. Some things you want to consider is it's not just what device you pick. There's also some preparation that could be helpful. So the Alzheimer's Society has a kit called a Finding Your Way identification kit. And that's where you would write down, what does this person look like? What are places they commonly would go to? A picture of your loved one. That way, if they ever went missing, you already have a description that you can give to the police, and that's ready to go. The other thing is I believe in Huron County, you can actually register that your information with the vulnerable persons registry with the police. So they actually already have a picture of your loved one, and they will know that if they see your loved one wandering around the streets, that's someone that they should bring back somewhere. So that's one thing that's a good pre-thing to do. The next thing I would suggest is your loved one should have some form of identification with them at all times. So options might be, a medic alert, safe and found medic alert bracelet, right? That says that they have a memory condition and gives a number to call. And if someone finds them and they call that number, it will give their name and address and their caregiver's phone number and kind of all of that stuff. The other thing that people will do though is they'll just, write out a card with that information, put it in the wallet, put it in the purse, sew it on the inside of someone's clothes, just make sure that they, wear it as a necklace, but always have that ability that if someone else finds them, they know where the person belongs, basically. And then the last piece, if you're looking for an actual technology, the University of Waterloo has the best website that I've come across with all the different technologies on it and information about how it works, the cost, the risks and the benefits, pros and cons, all that kind of stuff. So in terms of in general with the technology, there's like 3 types of tech options. So one is radio frequency, and that uses radio waves. It's not affected by being inside a building typically. So say your loved one gets lost in a mall, that type of technology might work well because it'll be able to kind of locate them in that setting. There's also Bluetooth. So Bluetooth signals, and again, I'm not a tech expert, but basically they require other devices within range, right? So most of them need to be within about 400 meters from, say, your phone to the Bluetooth device to be able to detect. Though I believe Apple has more of a network of Bluetooth. Again, maybe Christy and Jeanette can explain better than me. And then there's also GPS. And those technologies, they tend to require a little bit more frequent charging, which can be a positive or a negative. They tend to have a lot more features, which can be positive or negative, but they do have more difficulty inside of buildings. So maybe not the best option for, say, shopping mall getting lost situation. Other things to think about are cost, whether it's going to be a one-time fee or like an ongoing monthly fee. The style, like is it a watch? Is it a keychain? Is it, how are you going to hook it to the person? What does it do? Like, how is it charged? So lots of things to kind of consider.
Absolutely. I was just going to add in Huron County, the radio frequency, and in Perth, the radio frequency program is Project Lifesaver. Oh, you've got that right there. That's great.
Yeah, so one of the most common ones, it would be the Project Lifesaver that uses the radio frequency, and it's done by the paramedic service in Huron and the victim services in Perth County. You can either pay upfront for it or you can sort of pay monthly is kind of my understanding. You wear a bracelet on your wrist or your ankle 24/7. You don't take it off. It works really well for people that aren't techie, right? Like it does not require any kind of connection to a smartphone or anything like that. It works well for retirement homes or long-term care homes too, again, because it just doesn't, there's no tech involved. There's no app they have to monitor or anything. And then how it would work is if your loved one goes missing, that you call the police, they turn on their radio frequency scanner and they say, oh, your loved one is right here. I would say that is a pro, also sometimes a con. I've had situations where people spend hours searching for someone before they call the police and I would say you want to call the police. That should be the first thing you do if you have one of these bracelets, right? Because that's the whole purpose of it, is to have someone come out and locate your loved one rather than spending hours searching. But this is a really good one that a lot of people use. Another one that a lot of people use would be using the Bluetooth that I kind of talked about. So like an Apple AirTag or an Android Tile Pro. You know, these things were designed for tracking your keys or your purse or your lost luggage. But they can be hooked to a person as well. And they connect to your cell phone or smart device. There does usually have to be sort of a proximity to your device. But they have a really long battery. They're really cheap. Generally, there's no ongoing subscription. So for some people that works. There's phone apps. So I've got a picture of my husband here. This was him at work last night when I was working on this presentation. So I track him on the GPS. So I knew where he was just from his cell phone linking to my cell phone. So if your loved one carries a cell phone or a smartwatch, that can work. And then the GPS devices, again, you ask Christy or Jeanette or go on that website that reviews the hordes of GPS tracking devices that are out there.
Mm-hmm.
That's
Absolutely,
terrific.
folks. Feel
Yeah.
free to call our offices with any questions about any of these devices. We'll do our best to help you find what works for you.
Mm-hmm. So the second question was, are hallucinations common in non-Lewy body dementias? And how can we treat or support seniors who have this type of issue? So the answer is, absolutely. So kind of studies estimate that, 30 to 50% of people with a memory impairment will have some type of, psychotic type of symptom at some point during their illness. So it might be hallucination, it might be, more of a disorientation kind of situation or a delusion or a paranoia, but yes, we often hear hallucination and we think of Lewy body dementia or we think of Parkinson's dementia. And in those types of cases, it tends to be sort of an earlier symptom. With Alzheimer's disease, it would tend to be maybe more of a later symptom sometimes. The other thing that I do see is it can be an early symptom in someone with a fragile brain and like a hearing or vision problem. So, if you Google, there's something called Charles Bonnet syndrome, for example. So if someone has gone blind or has very low vision, they tend to be more prone to visual hallucinations. And it seems to be that just, their brain has lost the visual input from the eyes and it's perceiving something and it kind of fills that information in, right? And it's perceived as a visual hallucination. And I find the same thing in people with severe hearing impairment, right? Is that their brain hears something, but they don't exactly know what it is or how to interpret it. So all of a sudden it's perceived as music playing or someone breaking into the house or someone whispering in the closet or whatever. In terms of what you can do, I would say, many people don't have insight into this symptom. So generally speaking, you want to resist the urge to apply logic or reasoning. Things that you do want to do, you yourself remain calm, use a gentle tone of voice. Make eye contact with the person, touch them on the arm, help them feel comfortable, acknowledge what they're saying, and reassure them that you will help them. And I put a web link if you need videos on how to do this. So as an example, you want to avoid saying, there's nothing there, you're imagining it, and say something more like, you're hearing something, you're worried, you're seeing something, you're upset, I'll help you. And for the people that do have some insight or maybe intermittent insight to the fact that this is not natural or it's not real, or other people aren't seeing it, is saying something like, this is very real to you, I know you can see it, I know you can hear it, it's caused by that memory condition that you have, and I'm here with you, I will help keep you safe, I will help, let's go do something else away from it, right? So just that idea of, again, just trying to kind of acknowledge what they're saying and reassure them that you're here for them. And we'll maybe kind of skip over. I had a little bit of information around medical things, but I just want to make sure we have still lots of time. So the third question is, my family and I are interested in learning more about how you manage mood for people with dementia. Mood can escalate to crisis and going back to old trauma and reliving it. How do you handle the lows? Medication? Is talk therapy even an option for people with dementia? In our case, it's relating to someone who's still pretty functional at home and independent. So I think that's another really great question. I kind of popped this figure on the screen, and hopefully you can kind of see my mouse, but this is a little figure, and along the bottom it has severity of someone's memory impairment, from like an early to like a very severe. And then on the top, or going up the side here, it talks about what symptoms are getting worse. And then it's got a line for cognitive function, and it's got a line for ADL, which is activities of daily living, or like their functional ability. And then it's got this line for what's called BPSD, or just like behavioral and emotional changes. And the whole takeaway I wanted you to get from this picture is that someone can still be pretty functional and still have pretty good cognitive ability, but that might be, the very peak of their behavioral and emotional changes, right? So it is very common for people to have this problem and kind of not know how to support their loved one with, whether it be depression, whether it be anxiety, whether it be paranoia, whatever it be. And I think with depression specifically, there's some contributing and confounding pieces that make it that much difficult for families to navigate. Because for a lot of people, there is like a grieving and a frustration with the memory impairment, right? So they have some insight. They know that it's very difficult, or their day-to-day, it's very difficult, that they're not performing how they want to, and they feel really negative about themselves, and that can be a challenge. Sometimes people are kind of stuck in the past, right? So they're not in the current, they're kind of stuck in the past, and that makes past traumas be really close to the forefront, right? So whether it be a relationship issue that they had in childhood, or, say past physical abuse that they had as a child, or they were exposed to trauma in World War II, or, whatever it is, they can be a lot closer to that in their mind. I have a lot of people that perceive they're alone, or that no one's visited, right? So even if someone was just there, as soon as they're gone from sight, it's like they were never there. And so then that makes them tend to feel sad. There can be an apathy, which is when someone just is completely withdrawn, has lost interest in everything around them. And sometimes people don't know, is that apathy or loss of interest part of the dementia, or is the person depressed, or is it both, or what's going on? And I would say in general, people tend to withdraw from social situations because they're overwhelmed, right? So they'd rather stay home than go out. And then that perpetuates, a cycle of being stuck on our negative emotions. So again, in general, what families can do, resist the urge to tell someone to get over it, or, rationalize, or, you still got lots of good years left, just forget it. Just empathize with them and say, this is really hard. I wish things were different. I'm here with you. Let's try to go do X, Y, or Z to take our minds off things for a while, right? To try to kind of get them on to the next thing. And then just like general things, you want to have a daily routine. Like people with memory impairment lose that whole sense of routine. So if you can have like morning, we get up at a certain time, we go for a walk, we drive for a coffee, we go to the library, we have lunch, we play crib, we read the paper, we watch our favorite show, we go to bed, or whatever it is. If every day has a predictability and a change in environment, mood tends to be a lot better. The second thing I would say is to establish purpose, or like purposeful activities. So people often lose the hobby that they used to be able to do. But the reality is that everybody needs a purpose, right? Like everybody needs a reason why they're getting up every day. It doesn't matter what kind of problem that you have. So you need to think of activities that the person can do to feel productive, even if they're different than what they used to do. And again, the support counselors can be excellent for trying to help you figure out what your loved one might like or might be able to do to give them back that sense of accomplishment and productivity. Physical activity. So, many reasons that everybody should exercise, but especially if you're having mood issues, put regular activity into your routine. Put regular social activity into your routine. Social isolation will make your depression much, much worse. So again, whether it's say a Minds in Motion program with the Alzheimer Society or something at the local senior center, keep some social activities. Spending time reminiscing can be helpful for some people. So, putting photos in a photo album, looking at old pictures, watching old family videos. Having scheduled one-on-one interaction. So, this could be families setting up a call schedule, like Mondays, so-and-so is going to call mom, Tuesdays, such and such, Wednesdays, so-and-so is going to visit. But it's just that idea of having regular social connection. Some families will hire somebody, so like a neighbor, a friend, a PSW, whoever, to kind of come and do some visits or take their loved one out for coffee or go for a walk or whatever it is. You can get volunteer visitors. Again, Community Support Services Central Intake can help connect you. Alzheimer Society has some volunteer visitors, so does Hospice and One Care. But again, it's just kind of creating a regular social connection. A visit journal can be helpful for a lot of families. So especially for people that forget what happened the day before, it's just that idea that every time a family member visits, you just write down in a little book, like, I visited and this is what we talked about. And then the hope is when that person is alone or the next day, they can look back and say, oh, look at all the fun things I did this past week. I've not actually been alone the whole time. To answer your question specifically, like, yes, people with earlier stage of dementia can certainly engage in different kinds of talk therapy. In our area, many people start with a referral to the seniors mental health team, or again, connecting with an Alzheimer Society support counselor. We can think of other kinds of therapy, right? So music therapy, recreation therapy, pet therapy. Antidepressants have been studied in people with dementia. Unfortunately, they seem to be about equal to the placebo effect, or, just kind of taking a sugar pill. So what I tend to do is I tend to offer an antidepressant after 3 or 6 months. If it has not been helpful, then we will taper off of that. And then that apathy piece. So if we find that because of the changes in the brain, the person has lost that initiative, they're very withdrawn. Sometimes we'll try different medications to try to help with that piece of things as well. All right, so zooming right along, the last question was, it kind of contains a lot of elements. So hopefully we can get some pieces out here. So the question is, Hearing on the news yesterday that a new test to detect a protein in our brain is giving similar accuracy as more expensive and invasive tests currently being used to detect dementia. Can you please explain how it works, the importance of detecting dementia early, and when Canadians can expect to get this test, and will it be covered by OHIP? So let's dig into that a little bit. So I think what this question is referring to is on CTV SciTech News earlier this week. They did a little article on a paper that was published in the Journal of the American Medical Association on Monday. And what it was basically looking at was a blood test to detect a protein that deposits in the brain and is a marker that someone might have Alzheimer's disease. So to understand that, couple of broad things you have to understand. So when we're talking about causes of dementia, there's sort of like two buckets. One is that for many kinds of dementia, there's an abnormal protein that deposits in the brain and kills the brain cells. So a lot of these different tests are kind of focused on the idea of, can we detect what proteins are deposited in the brain and causing the problem without taking out brain tissue, right? Or doing a brain biopsy, because we can't do that while people are living. The other kind of broad bucket of dementia is like vascular changes, and that's where you've got damage to blood flow up to the brain. So again, these tests are really looking at sort of these different proteins and trying to predict what kinds of dementia you have. And if we're talking about Alzheimer's disease specifically, which this study is referring to, this figure, again, along the bottom, it's got progression of someone's dementia. So from normal to having significant dementia. And along the side here, it's got level of abnormalities of these markers. So what you can see here is that even a person that is normal from a cognitive perspective, if they are on a path to developing Alzheimer's disease, we will start to see this black line abnormal protein deposit in their brain called beta amyloid. Then again, they're still normal in their cognition, but several years later, we start to see this blue line, which is this tau mediated damage in the brain. Then we start to see this green line, which is a change on the person's MRI scan or their CT scan of the head. And then later on, we start to see the red line where a person has symptoms of Alzheimer's disease. So the thought is, can we pick up these markers in the blood before a person has full-blown dementia, with the idea that maybe we can, reduce the progression of that person developing dementia. In terms of what's currently available in Canada, so currently in Canada, we use clinical diagnosis of Alzheimer's disease. And what does that mean? We listen to the person's story, we do a neurologic examination, we do memory testing to determine what areas they're having difficulty with, and we do blood work and other things to kind of exclude other causes of memory impairment. And then in the year 2020, our guidelines said, we think you also better do an MRI or a CT scan of their head. So now we also do a scan of your head and we look at the patterns of shrinkage. So remember I said that, first you have the amyloid, then you have the tau, then you see the shrinkage, and then you get the symptoms, right? So this is what we can do right now in Canada. What is available in the United States and in research settings is what's on the right side of the page. And that is a few different things. One is called an amyloid PET scan. And that is where we basically we inject a substance into your bloodstream. It goes to the brain and binds that amyloid protein that we know is deposited. And then when we do the scan, it lights up. and it'll tell us how much of this amyloid protein you have in the brain. The next test, again, not available right now in Canada, but is available in the United States in research, is what's called a lumbar puncture, to take the fluid out that surrounds the brain and the spinal cord and send that for this amyloid and tau levels, basically. And then the third thing, which is, again, not available in Canada, but it's what this article is talking about, is actually measuring the levels of these markers in the bloodstream. So we definitely think that measuring things in the bloodstream will be cheaper. It will be way less invasive. So that's what everybody's aiming for, is this blood test. But just again, so that right now, actually none of these tests are super available in Canada outside of sort of a research setting. And again, I mean, you asked, why is this important? It's important because in the United States, over the last 2 years, there's been several medications approved that you give them intravenous into the bloodstream, they go to the brain, and they bind that amyloid protein, and they get your body to destroy it and kind of remove it. And these medications have been tried in people that have significant dementia, and they do not work. Most recently, they've been tried in people with very early stage. So kind of that idea that the amyloid is deposited, the tau is deposited, but you don't have any symptoms yet. If you use them in that population, you seem to delay the progression to dementia. And so in the studies, it seemed to be by about 6 months. And so we anticipate that this medicine may become approved in Canada in the next year or so. And in order to use this, I'm going to need to know who has the amyloid and the tau in their brain. So the government is going to have to approve some kind of, whether it be the amyloid PET, whether it be the fluid, taking the fluid out, or whether it be these blood biomarkers. And again, probably taking it, if the bloodstream test is reliable, then probably that will be the cheapest and easiest for many people. So I hope that kind of explains where that news article is coming from. It certainly is exciting that we are able to sample your blood and tell you, what is going on in your brain.